Good morning, everybody. I'm Janita Holt with Forge Breast Cancer Survivor Center, and I'm here with Dr. Fran Hoh, the founder of Palliative RX today for our coffee conversation. Thank you for tuning in with us this morning, and thank you for joining us, Fran. If it's okay with you, we would love to get this conversation going. So if you could you just tell us a little bit about yourself?
Sure. I am an advanced practice nurse. I live and work in New Jersey. I've been a nurse for over 4 decades. I've done critical care. I've done geriatrics. I ran an inpatient pain service for 10 years. And now I am one of the palliative care advanced practice nurses at a rural hospital in New Jersey doing palliative care.
Wow, thank you so much for joining us today. Can you give us some background on Palliative RX, just its founding, the services and resources that you all provide?
Sure. So Palliative RX is new. We started this last year in 2020. My original business was Always Think Comfort, which provided palliative and pain consultant services to long-term care facilities and assisted living facilities in New Jersey. But then last year, we expanded that to Palliative RX, which is which we provide online education for patients that are suffering with serious illness. So we have 5-week programs on cancer, on pain management, several different programs for people that are suffering with chronic illness with a hope to help them take better control of what's going on with them, better understand what's happening to their body, better be able to advocate for themselves and take care of themselves so that they don't feel like they're on that roller coaster all the time. And we can really, help them with some strategies to manage everything that comes their way. So, I think with the COVID epidemic, everybody was so isolated. People weren't going in to see their providers. If they were going to support groups, they weren't online initially in the beginning. So, that's what drove us to create these programs online so that people can now come online and take advantage of, getting some education. We also have a Facebook group that's called CHF COPD Cancer and Dementia Education Support. And each month we have a different theme and we offer resources on that group and people can kind of share with each other and get information. And we have Facebook Lives every week where we kind of talk about what's going on with the topic of the week. So that's how we're offering education to the community out there.
I think that is so awesome. Especially just in light of the pandemic happening and so many resources just, not within grasp. So creating something like that is amazing for you.
Can I interrupt? I just have a question. Can she repeat what that Facebook page was? It's
CHF, COPD, Cancer and Dementia Education and Support.
Thank you.
You're welcome.
Well, okay, Dr. Franz, when you're ready, if you could please begin your presentation that you prepared for us today.
Sure. So we're going to be talking about pain today. I mean, that's one of my true loves. So I thought we would do a little bit with the objective of helping you all understand, a little bit more about what your pain is and why it's happening and how we treat it and ways to talk to your doctor and, just hoping to give you more control of what's happening. Sometimes I see a lot of cancer patients in the hospital and, I feel like their pain is not as managed as it could be. So I always think that the more education is power, and the more we know, the more we can empower ourselves to advocate for ourselves. So that's the purpose of this presentation today. So I often say that pain is like the good, the bad, and the ugly. Pain is good because it's like an alarm. It tells us something is wrong. If your appendix is going to burst, you're going to have pain in your appendix, which is the body's way of telling you need to seek medical care. Pain can get bad when we have it every day. and it prevents us from doing the things that we want to do. And we really can't live our life the way we want, and it impacts our quality of life. And that's when pain gets bad. Pain gets ugly when we can't get out of bed. We can't get dressed. We can't socialize with our family. And it just stops us in our tracks. And that's really what we never want to see. You know, statistically speaking, 95% of the time, we can control pain with medications alone. And that's the hope, is that we can get your pain controlled so that it never gets to be ugly. When we think about how pain affects us, you know, pain affects us. It's not just a physical thing. You know, pain is an emotional thing. You know, a lot of people get angry. You know, you've often probably heard someone say, "I'm sorry, I didn't mean to snap at you. It's just that this pain is just so bad." So sometimes people get very frustrated and very angry because the pain is constant and they can't get a control over it, and it just has an emotional impact on them. You know, sometimes there's the little dwarf Sleepy in the corner. Sometimes the medicines make us tired and we just want to sleep all day because that makes us not feel the pain if we just sleep all day. But that's not a solution either. You know, sometimes in the bottom right corner, you know, we feel very isolated. Nobody understands us. Our families are tired of hearing us complain about our pain. So, you know, we feel very isolated and that there's no one to go to. In the top right corner, that's me and my friend at the Grand Canyon. You know, sometimes we can't socially do the things that we want to do. We can't be out and about and doing what gives us pleasure because the pain interacts with that. So pain is never just physical. Pain is social, pain is spiritual, pain is psychological, pain is emotional. So there are many characteristics. So when we talk about what pain feels like, I don't know why this keeps going back. There are many words that we can use to describe pain, and we call this the quality of our pain. So quality is things like, is it achy? Is it crampy? Is it sharp? Is it burning? Is it pins and needles? Is it numb? Is it dull? Is it all over? Is it in one spot? How do we describe our pain? Is the quality. And it's really important that we get a handle on the quality, because that helps our providers figure out what's causing the pain. So the more specific we can be, the better. You know, one thing I've learned in doing pain for so long is that in the English language, we have a lot of words for pain. I just listed a whole bunch of them. But in other languages, they don't have so many words. So when you say to a patient where English is not their primary language, tell me what your pain feels like, they look at you like it's pain. It feels like pain. It hurts. It's pain. They don't know all the other words. So we have to, you know, always try to be as descriptive as we can. The second way we evaluate pain is quantity. And most of you have probably heard people say, on a scale of 0 to 10, how much pain do you have? The FACES scale, you know, this started out being used in children. That's what's under the 0 to 10 scale. So basically 10 is the worst pain you could ever imagine, and 0 is none. So sometimes patients have a hard time with the numbers. So I'll say to them, is it mild, moderate, or severe? Generally, mild pain is 1, 2, 3, moderate is 4, 5, 6, and severe is 7, 8, 9, 10. So there are many barriers to effective pain management. You know, there are some patient barriers. You know, patients will say, oh, I don't want that medicine now because then when I really need it, what am I going to get? Or I don't want to take that because it makes me constipated. I'd rather have the pain than be constipated. Or I don't want to become addicted, so I don't want to take that medicine because I've been watching what's on the news about people getting addicted, so I don't want it. So there are many barriers that patients and families have that prevent them from getting adequate pain management. There are physician barriers. You know, there are many physicians, especially in this day and age now, that say, I don't prescribe, I won't prescribe, I can't prescribe. You know, if a physician has a DEA number, he can prescribe. Very often, though, they don't want to prescribe because we're in the middle of an opioid epidemic. Many times the physicians, maybe they're older and haven't been taught, how to manage pain effectively. Back in the 70s and 80s, we didn't use pain medicines only for cancer pain. We didn't use it for other types of pain. So sometimes physicians may not be comfortable knowing exactly what types of medicines or combinations of medicines to give. And then we have system barriers. Right now we have a insurance dilemma that is a big barrier to my patients. You try to order a pain medicine, insurance companies want a pre-authorization, not only for the drug, but they want a pre-authorization for the dose. So we have to do 2 pre-authorizations. Many pharmacies are not carrying the drugs because they're afraid that people will come and steal them. So you can't get access to your medications that you need. So there are many system barriers that make it difficult for us to get appropriate pain medication. Some of the common side effects that we have, constipation is the biggie. Generally, this happens in older patients. I don't see it as much with my 30 and 40-year-olds, but my 50, 60, 70, 80-year-olds have a problem with constipation. So in order to combat that, whenever you're on opiates that you're taking every day for pain, you really should be on what we call a bowel regimen. So a bowel regimen includes generally stool softeners and laxatives. Generally, it's not a good idea to take one without the other. If you take a stool softener but no laxative, I always tell patients you have mush and no push. So we need a laxative to push the stool through, and we need a stool softener to make it soft. So anybody who's taking long-acting pain medications or, pain medications every day, opioids, should be on a bowel regimen that consists of a stool softener and a laxative. People are often concerned if they're able to drive. Generally, the standard is if you're starting a new opiate drug or you're increasing the dose, you should avoid driving until your body gets used to it. But once you've been on it for a week or so, and you know that you're able to handle the drugs that you're on, then you are able to drive. There is no rule that says you can't drive if you're on an opioid. Sleepy feeling, very often when we start taking pain medicines, and I'm referring to specifically opioids right now, we get sleepy. That's something that we develop a tolerance to, and that will pass over time. That generally happens for the first 3 to 5 days, and then that will go away. Inability to concentrate. A lot of patients say to me, I don't like that foggy feeling. I feel like my mind's in the clouds. Sometimes you might need to switch and try a different opioid. If one of them is making you feel cloudy or foggy, you might want to try switching to another and see if that feeling goes away. Nausea and vomiting. Some of the drugs cause the side effect of nausea and vomiting. I always tell patients to take it on a full stomach with food, not to take it on an empty stomach. And that sometimes will help the nausea and vomiting. Sometimes you need to switch, the medicines as well. I'd like to just spend a moment talking about what addiction is and what it isn't, because I think a lot of people are confused about addiction. I've had patients come to me and say, well, I think I'm addicted. And I say, why do you think that? Well, I need it every day and I'm taking it like 3 and 4 times a day. So I must be addicted. If you have diabetes and you're checking your sugar several times a day and taking sugar medicine or insulin, you don't think to yourself you're taking too much. It's what you need to control your sugar. Just like pain medicines are what you need to control your pain. So I always like to make sure people really understand what addiction is so that, they don't misconstrue that they have addiction when really it's not addiction. So addiction is a primary, chronic, neurobiological disease. So primary means you can have addiction with nothing else. Sometimes we see it in patients with psychiatric issues, but it can occur by itself. It's chronic, which means it comes and goes. Sometimes people can be addicted, then they'll get sober and clean, and then they'll become addicted again. So it's not something that you can fix and it goes away forever. It's neurobiological in the sense that it affects the cells in our brain, the mu receptors. We change the receptors in our brain. Once we start taking pain medicines, we change the receptors, and then those receptors need the medication. So it's what the receptors need, so it's neurobiologic. We also know there's genetic factors involved. Very often when you talk about addiction with a patient, often if the patient is addicted, they also have family members that also have an addiction disease. It's psychosocial and environmental. You know, sometimes if we are living in an environment where drugs are common, you know, you come home every day and people in your house are doing different drugs, or you live in a neighborhood where drugs are being sold on the street, you know, that may seem more the norm to you than if you didn't grow up in that type of environment. So there are some psychosocial and environmental pieces of addiction as well. And when we look about the characteristics of addiction, basically there are four. We call them the 4 C's. One is impaired control. That means that you can't just take one. You're constantly taking your medicine. You know, I sent a patient home from the hospital one day who had a history of addiction, who was doing fine on his medicines in the hospital. And I said, so I was going over his discharge instructions and how to take them. He said, well, I don't know if I could just take one. And I said, well, what do you mean you don't know if you could take one? And he said, well, back in the day, he said, I would wake up in the morning, pour a handful of pills, take them, and then just start my day. I don't know if I'd just be able to take one pill, even though that's what he had been taking in the hospital. So people have impaired control over drug use. They can't just control how much they take. There's compulsive use, which means they just want more. When am I going to get more? How many pills do I have left? How many pills are you going to give me? Are you going to give me more pills? It's compulsive use. Continued use despite harm. You've gotten arrested. Your family wants nothing to do with you. You get into fights. You fall down the stairs because you're using too much drug. That's continued use despite harm. And craving. Craving means you're always looking for that drug. So these are the signs of addiction. If you feel that you have them, then you should probably talk to someone about that. People that have chronic pain, you know, pain that's there all the time, need pain medicine to take care of that pain. You know, we need to be aware of what our risk factors are of addiction and talk to our provider about that if we've been addicted before. You know, the problem is that patients are often afraid to tell their providers that they have a history of addiction because they think that their providers won't give them pain medication. But the fact is you really have to be honest, and you have to have a provider that you trust. And if your provider says absolutely not, then you need to find another provider. Because even with a history of addiction, we can treat pain. And we may treat it with non-opiates. You may need a non-opiate plan. And many of my patients are on non-opiate plans. But the conversation has to occur. If you have a fear of addiction, because maybe you've had family members that have had an addiction problem or died of an overdose, that's something that you need to talk to your provider about. Because again, as we said before, that puts you at risk. But there are support systems available, and we need to find what they are.
I think that it's awesome to, let individuals know that even if you do have an history of substance use or within your family, there are other methods to treat pain other than opiate drugs. I think that's a gem for individuals to know.
Yeah. And I think people are just afraid. They're so afraid because there's such a stigma. So people are afraid to say, and if you have a provider, you have to have a trusting relationship. And I always say to people, I'm not the police. I'm your provider and I want to help you have the best quality of life that you can. And in order for me to do that, we need to be open and honest with each other. I'll tell you what I think. I'll tell you if I think you're at risk, and you need to tell me what you're afraid of. So when you're speaking to your doctor about pain, you really want to try to be as specific as possible. The more specific you can be, the better they're able to treat you. So when did this pain start? Have you had it for months and it's gotten worse and worse? Or did it, out of the clear blue sky, maybe you coughed or you lifted something out of the trunk and then all of a sudden the pain began? When is it worse? Is it worse when you wake up? Or is it good in the morning and it's worse when, you've been, taking a walk or doing your exercise or coming home from work? When is it better? What makes it better? Is it better when you lay down? Is it better when you walk? Is it better after you take your pain medicine? What does it feel like? Those characteristics I gave you earlier. What does it feel like? How long does it last? Is it something that's there all the time, or does it come and go? So it's really important that you be as specific as you can. Be specific about the location. Now, I'll often say to patients, point to me with one finger where your pain is. And they'll say, oh, it's all over here. I'll say, that's not one finger. I really need to know specifically where is the pain the worst, because that helps me figure out what might be the cause. What are other symptoms that you have that are associated with the pain? Are you nauseous? Are you unable to sleep? Are you depressed? Does the pain happen after you eat? Be specific. Describe the severity. We talked about quantity on a scale of 1 to 10, or mild, moderate, or severe. Tell them how severe it is. What are the medicines that work a little? A lot of patients say to me, well, that doesn't work. And I say, well, did it work at one time? Or does it work a little, but not enough? Because you have to figure out which meds are good, which medicines don't work at all. We've learned that genetically, we all metabolize drugs differently. So I may take a Percocet and throw up for 7 hours. Janita may take a Percocet and she may have total pain relief and be functioning fine. Someone else may take a Percocet and it may have no help at all. So genetically, we all metabolize these pain medicines differently. So that's why it's important for us to know what you've tried, what has worked, and what hasn't, and what side effects you have when you take these medicines. I always want to mention allergy versus side effects. A lot of people will tell me they're allergic to codeine. And when I say, what is your allergy? They say, I throw up and I get nauseous. That is not an allergy, that is a side effect. The problem with telling people you're allergic to one pain med is when that goes on your record, the pharmacy, it will trigger any other pain med that they want to give you. So if you really don't have an allergy, if it's really just a side effect, we don't want to have it documented on your record that it's an allergy, because this way, they will not want to give you any other medicine. So you have to be specific about that. What are your rights as a patient? You have a right that your pain is going to be evaluated and managed. That is your right. When you are in the hospital, in a Joint Commission accredited hospital, one of Joint Commission's requirements is that your pain is evaluated and managed. If you are in a cancer institute who is credentialed by the Commission on Cancer, one of their standards is that your symptoms are going to be controlled and managed. You have the right to have information about what your options are. If this doesn't work, what is another possibility? You have the right that your provider will believe you. When you tell them that you have severe pain, they will believe that you have severe pain and treat it accordingly. And you have the right to information about side effects. What are the side effects that you can potentially experience with these medicines? You also have responsibilities as a patient. Your responsibility is that you tell your provider what kind of pain you're having, as we described before. Many cancer patients have been found to say, oh, well, I don't bring it up. If my doctor doesn't mention it, I don't want to mention it, because if he doesn't mention it, then I probably shouldn't be having this pain. and I want to be the good patient, and I don't want to, make him think I'm a drug seeker, God forbid. But if the doctor doesn't bring it up and you're having pain, it's something that you need to bring up. You need to keep a record, especially if you're on a long journey and you've tried many different things. You need to keep a record of the medications you've been on, the doses you've been on, and what effects they've had. You need to be honest about your concerns. If you're concerned about addiction, you need to talk to your physician about that, or your provider. And you need to keep a pain journal or a pain diary. The responsibilities of your provider is that they will listen to you. They will prescribe you something. And if it doesn't work, they will prescribe you something else. They will refer you to other healthcare providers when that is appropriate. They will alert you to the side effects that you may have. And they will use a variety of both drug and non-drug approaches to alleviate your pain. And this is something that you should be asking about. If they're I always tell patients that an opiate-only pain regimen is never a good regimen. There should always be other things that you're on. So what are the types of doctors that treat pain? Some people may go to a pain doctor who's an anesthesiologist, a doctor that generally gives anesthesia in the operating room. But those doctors have also been trained how to give different types of nerve blocks and different types of injections. You may have heard the term epidural steroid injection, where they go into your back and they inject a steroid and maybe a lidocaine, or a nerve block if you've had surgery. If you're having hand surgery, they may give you a block up here to numb your hand so that you won't have pain post-op. So that's one type of pain doctor. Physiatrists are another. These are doctors that set up physical therapy for you. And they're also trained in different techniques to help with pain management. Addictionologists, those are doctors that help you if you have a history of addiction or you're becoming addicted to your pain medicine, you would go to an addictionologist. Psychologists, we talked about the fact that oftentimes we have psychosocial and emotional consequences of our chronic pain. And we might need to talk to someone about that to help us understand our feelings and how we feel about having chronic suffering. So when you go to a pain specialist, there are either interventional or non-interventional. Most pain specialists are interventional. They do procedures. I am a non-interventional. I use medication and non-pharmacologic modalities. Some specialists will do nerve blocks or steroid injections, as we mentioned, or medication management, like what I do. So we talk about different types of pain, and in the beginning I said, the better you can describe it, the better we can figure out what type you have. So some of the terms that we use are somatic pain. So if I sprain my ankle or break my leg, that's considered a somatic pain. A visceral pain starts in the organs. So if I have liver cancer, or if I have an appendicitis attack, or if I have menstrual cramps, that's considered a visceral pain because it's arising out of an organ. If I have diabetic neuropathy, or I have post-herpetic neuralgia, or I have trigeminal neuralgia, that's neuropathic pain. It's arising from the nerves. So these are different types of pain we have, and it's different. It's good to know the different types because there are different pain medicines to treat different types of pain. So if you have neuropathic pain, I'm not going to give you the same drug that I would give you if you have a somatic or visceral pain. So over-the-counter pain medicines are the #1 over-the-counter medication sold. So if you have pain and you go to the drugstore, you can get Tylenol, you can get Motrin, Aleve, ibuprofen. different types of anti-inflammatory medications. You can get pain patches, Lidocaine patches, or menthol patches, or Bengay patches. There's lots of different things you can get over the counter. And a lot of patients will just get over-the-counter medicines until they don't work anymore and they need to see a specialist. So there's a big concern about Tylenol. Tylenol can cause damage to the liver if you take too much of it. So generally it was 4 grams a day, which was the amount of Tylenol that people can take. That's the maximum. But then they said, well, there's a lot of other medicines that have Tylenol in them. Some sleeping medicines have Tylenol. Some cold medicines have Tylenol. Some cough medicines have Tylenol. So if I'm taking Tylenol and then maybe a sleeping medicine that I don't know has Tylenol in it, I may be over the daily allotted amount, which is 4 grams per day, or that would be equal to 8 extra strength Tylenol, because each extra strength Tylenol is 500 milligrams. 2 of them would be 1,000 or 1 gram, and 8 of them would be 4 grams. So if you have a history of cirrhosis or hepatitis or liver problems, or you drink alcohol more than 2 to 3 drinks a day, you need to be very careful with taking over-the-counter Tylenol, because you could really mess up your liver. Anti-inflammatories are another common drug that we take. They also come with side effects. The big side effects of anti-inflammatory drugs, they can cause GI bleeds. So if you've had a history of a bleeding ulcer, that puts you more at risk to get another one if you're taking anti-inflammatories. So you need to discuss that with your provider if you've had a history of a GI bleed. The other big problem with anti-inflammatories is kidney failure. And a lot of people take a lot of anti-inflammatories and it can really shut their kidneys down. So we need to monitor kidney numbers when we're taking NSAIDs. It can also make you bleed, and you have to be careful if you're taking other anticoagulants when you're taking NSAIDs, because it can increase your risk of bleeding. And way back when, back in, God, I don't even remember, was it the 90s? There were anti-inflammatories that came out. Celebrex was one of them. Vioxx and Bextra were other ones, and they came off the market, 2 of them, because they could cause heart attack and stroke. So those are some of the other side effects of taking the anti-inflammatories. So when we talk about prescription pain medicines, NSAIDs would be one prescription. We can give you a prescription for anti-inflammatories that are stronger than what you get over the counter. There are opioids. There's drugs like Ultram or Tramadol. And then there are drugs that are called adjuvants. These are helper drugs. Drugs like steroids or anti-seizure meds or antidepressants. These are all drugs that help the pain medicines work. When we take opioids for pain, there's basically 2 kinds. There's long-acting and short-acting. Short-actings work 3 to 6 hours. They kick in and wear off. Long-actings work over the day, so you avoid the peaks and valleys. So when you have pain, I tell people, if you have pain that's 24/7, you need a drug that works 24/7 and not a drug that works for 4 hours. A lot of times when you take a long-acting, that decreases the anxiety of worrying, when is my medicine going to wear off? When can I take another one? Because you've got drug in your system all the time. So it's a more reliable delivery method than that up and down, peak and valley of the short-actings. Some examples of short-acting pain meds are codeine, Dilaudid, Percocet, morphine, roxicodone, which is oxycodone, which is also Percocet. These are some examples of short-acting pain meds. Long-acting examples would be drugs like Duragesic patch, which is in the picture there, MS-Contin. If a drug has the word Contin in it, that means continuous. So we have MS-Contin, which is a long-acting continuous morphine. And we have OxyContin, which is a long-acting continuous oxycodone. Methadone is another example of a long-acting opiate, and Exalgo is the long-acting Dilaudid. Other medicines that we use are a Lidoderm patch. This contains lidocaine, which is the same drug they give to numb your mouth or to numb you if they're going to give you stitches. It's a patch that you wear for 12 hours on, 12 hours off. You can wear up to 3 at a time. It may take 2 weeks to kick in, and this is best used for nerve types pain, diabetic neuropathy, post-traumatic neuralgia, phantom limb pain are all good for Lidoderm patches. Things that increase your pain. You should always be aware of things that make your pain worse. Things like anxiety. The more anxious you are, the more pain you will have. Sleeplessness. If you don't sleep enough, you're going to have more pain. People that don't have support systems often have more pain. Other stressors like financial, social, spiritual stressors. All of these things increase pain. So when you're looking at controlling your pain, you don't, and that's why I said before, it's never just physical. There's always other things going on. So some pain relieving activities that you can do, use distraction, listen to music, put headphones on, watch a movie that's a comedy. Laughing releases endorphins, which are natural pain relievers. Do games or puzzles to get your mind off your pain. Imagery, go somewhere in your mind, you know, fantasize about being on an island or being at a place where you vacationed. Do relaxation exercises, do deep breathing exercises to relax. Lose weight, that often helps. Sometimes the heavier we are, the more weight we carry, the more pain we have because the more pressure we have on our joints. You know, obesity today is another public health crisis. So the heavier you are, the more pain you will have. I always say imagination can take you anywhere, even over the rainbow. So if you just imagine, just think about being in a place that you love to be, sometimes that can help with your pain. Keep a pain journal. In your journal, describe the type and severity of your pain. Write down what medicines you took, how the medicines worked, what other symptoms you had. Were you nauseous? Were you itchy? Were you, having trouble sleeping? What were you doing when the pain came on? Did you just have a fight with your boss? Did you just exercise or do physical therapy? So keep a pain journal and bring your journal when you go to your provider so that they can look at it with you. So to put it all together, you want to tell your provider as much as you can about your pain. You want to keep a journal with what you've tried and what kind of pain you have. And if your provider can't relieve your pain, then find one who will. Because it's really important that we be heard. So in closing, I'm going to say having the courage to ask for what you want is half the battle. So you need to be sure to tell your provider if your pain is not managed. Just because they're giving you something doesn't mean that there's nothing more they can give you. Doesn't mean that you shouldn't ask. Just because they don't bring it up doesn't mean that you shouldn't ask. If you're having pain and it's interfering with your daily living, you need to be discussing it with your provider. And I think that's it.
Thank you so much for that, Fran. I think that is awesome because oftentimes I've even caught myself when I would go to the doctor, especially after, I had one of my children and I didn't want to mention, my horrible back pain, like if he didn't talk about it in my mind, I was like, well, I must not, need to address it. If he's not saying anything, I shouldn't say anything. So I think that is just an awesome reminder to anyone who's going to talk to their physician. If there's something that you're experiencing, just because the doctor doesn't bring it up doesn't mean that it isn't real and that you shouldn't talk about it.
Exactly.
Yeah. And I know earlier in your presentation, you were mentioning all of these different barriers, the systematic and the physician and the personal barriers that individuals might have when they want to discuss their pain or when they want to address it. Can you kind of give us some tips on what ways a person can kind of overcome that or can, navigate through that when they're talking with their provider?
It's really hard not to have a lot of emotion, If you're struggling with pain and you can't sleep, that makes you more stressed. You have pain, that makes you more stressed. Then you have a provider who's not making it better, that makes you more stressed. So it's really easy to go in and, be yelling and screaming and carrying on or crying or hysterical, and sometimes, you're not as heard when that happens. So just try to remember to be as calm as possible, as hard as that is. Maybe write things down before you go in. Write the specific points that you want to talk about so that you have it written down and it's easier to just stick to your, what you have written down. And, just continue to advocate for yourself. If they say, there's nothing they can do, just give them examples of the things that you're unable to do during your day because of the pain. And, what advice can they give you to make this pain better? Because, you just can't live like this. And just be, don't give up. Don't let them talk you down or tell you that what you're feeling is not real.
Thank you so much, Fran, for all of this education that you've given us today. It's been a wealth of knowledge. We want to thank everybody for joining us on today to discuss pain management. And we hope to see you all next time.
Thank you.